Good morning, everyone. Welcome to the webinar session today. Don't let the opportunity pass, integrating STI into HIV services. My name is Georges Perrin, Technical Advisor at AFO, WHO Regional Office for Africa based in Brazzaville. I'm part of the HIV, TB, hepatitis, and STI unit team within the UCN cluster, Universal Health Coverage, Communicable and Non-Communicable Disease. On behalf of the AFO team, I'm delighted to have you join us today in this webinar. The objectives of the webinar, they will present rationale for the integration of STIs in HIV services, will provide current normative status for the provision of STI services for people on HIV PrEP, focusing on African countries. This webinar will provide practical guidance to policymakers, program and facility managers, and other health workers to support implementing and improving STI service integration in the context of HIV service provision by using a stepwise approach. Finally, this webinar will highlight facilitators, barriers, and lessons of integrating STI services in different settings and populations in Africa. Next slide, please. Before we start, please note that this virtual training adheres to the Code of Conduct to prevent harassment, including sexual harassment at WHO events. Next slide, please. This is the agenda. This webinar will last 19 minutes. We'll have, 5 presentations, and also we have, a voice of the community video from South Africa. And a Q&A session will be at the end of the presentation. Over. Next. The Q&A session, you can use the Q&A feature for questions regarding the topic and presentation. Only question in the Q&A will be answered during the session. Live question will be taken at the end of all presentations. Use the chat feature for questions regarding IT or logistic. Next slide. Interpretation in English, French, and Portuguese are available by clicking Interpretation button. Click on Interpretation and choose the language that you would like to hear. To hear the interpreted language only, click Mute Original Audio. Next slide, please. Live transcription is available for this webinar. You can click on Show Captions, and caption will appear on the screen. To close the caption, click Hide Captions. Next slide, please. This session is being recorded, and we take your attendance as a consent to be recorded. Recordings will be shared after the session in English, French, and Portuguese. Session materials, including session recordings, will be emailed to the participant in the days following the webinar. As we continue to improve our training programs, your feedback is invaluable to us. A survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will help us tailor future sessions to better meet your needs and expectations. Now we'll move to the first presentation with Erika Spielman. Erika Spielman is a clinician with both experience in Southern and Eastern Africa, focused on HIV prevention, care, and treatment, as well as in the US, focused on adolescent reproductive health and STIs. She is now based in Geneva, working with the WHO HHS team in the testing, prevention, and population unit. Erika will talk about the national recommendation for STI management among people who use HIV PrEP in the African region. Over to you, Erika.
Thank you very much, George. Thanks everyone for joining us today. I hope my slides are visible at this time. As George said, I'm going to be talking about the national recommendations for STI management among people who use HIV PrEP in the African region. So really just to start, we know that there's a high STI prevalence and incidence among people who would benefit from or who are on PrEP for HIV infection. This is not new news, but it's something that's really important and why we even started looking into this issue at all. So, for example, a systematic review was done. On the left-hand side, you see for the prevalence of people prior to starting PrEP. And this was done, the cohort was mostly men who have sex with men. And you can see here that there was a 11.6% prevalence of gonorrhea prior to starting PrEP. And if you look at the chart below in blue, men aged 15 to 49, the general prevalence in the African region is 0.7%. So 0.7% compared to 11.6%, huge, multifold increase of those who are seeking PrEP. On the right-hand side, we looked at cohorts of African women age 18 to 25. And again, the prevalence of gonorrhea and chlamydia was extremely high, anywhere in gonorrhea from 4% to 10%, and for chlamydia, 12% to 29%. And if you compare it to the general population of women age 15 to 49, gonorrhea is 1.6% in the general population as compared to 4 or 10%. So again, 4 to 10, five-fold increase. For chlamydia, it was 5.5 in the general female population, and the prevalence could be up to 29% among people in PrEP cohorts. So we can see where the issue is and why this is really important. There is work that's already being done around this, both with systematic reviews and research, but with some guidelines and guidances. We have the WHO Global Health Sector Strategy, which is starting to address this, and a newer consolidated guidelines on HIV, viral hepatitis, and STI prevention for key populations. And on the right-hand side, you'll see the PrEP Toolkit, the latest module of this, which is integrating STI services, which my colleague Maive will be speaking about after this. So to start off, we wanted to do a review of national normative documents, really to set a global baseline for the inclusion of STIs in national HIV PrEP guidances, to identify priority gaps on guidances within the provision of STI services, and to inform the development of the new module that Maive will be speaking about next, and to inform research priorities and opportunities. So I'm going to try to keep this brief, and right now I'll speak a little bit about the analysis of the STI information within national HIV PrEP, really pulling out and highlighting the top 5 or 6 messages that we gained from this information. So first, just to share, the total number of African country guidances that were attempted to be found and reviewed were 47, and that's 47 of the WHO members countries. 32 of those actually did have PrEP guidance, and 22 included STIs. So fantastic, 69% include STIs in PrEP guidance. But there is that 10 between the 32 and 22 difference, which it's a very small addition to include screening for STIs when people come in for PrEP services. So it really is a missed opportunity not to include it in those 10 guidances. Also, just in general, looking at the target PrEP populations, all PrEP guidances that included STIs overtly mention key populations, and most include pregnant women and adolescents. This is fantastic. It means they're on the radar. We're targeting the right populations. Inclusion of this information in guidance documents may encourage the provision of STI services for these populations. So it's really essential that that's in there. Looking at the number of PrEP guidances documents that indicate the type of STI case management was something else we looked into. So 10 out of the 22, so about 45% of them that mention the type of case management include syphilis testing in addition to syndromic. So they've mentioned syndromic, and then they've said also screen for syphilis and actually how to screen for syphilis in terms of type of testing. 7 countries did mention syndromic only, and 5 countries did not specify what kind of case management. So it seems that the inclusion of syphilis testing is feasible, can be feasible in the African context. So we're going to break down syphilis a little bit more. If you recall from the previous slide, there was 10 countries that identified syndromic and syphilis. 3 of those countries didn't specify what kind of testing to do for syphilis, but the remaining 7 did. 2 talked about treponemal tests, 2 talked about non-treponemal tests, and 3 talked about treponemal and non-treponemal. 4 actually mentioned RDTs, rapid diagnostic tests, 2 of which were part of the treponemal, and 1 actually included dual HIV syphilis, which is fantastic. So the potential for inclusion of RDTs to screen for syphilis, including dual HIV syphilis, is really important. We know that according to 2023 GAM data, the most recent, 21 countries reported use of dual HIV syphilis RDTs among key populations. However, this was not really reflected in the guidance that was reviewed. So there's a gap, and part of it is probably just catching up, but it's something that really can be included in guidance. In addition, it was, there's concern because a non-treponemal test is essential to confirm active infection. We know that in most cases, treponemal tests only remain positive for life. So in order to really capture those active infections and have a better sense, there needs to be a non-treponemal test included. Thus, moving to syphilis algorithms is really important. Finally, just to mention that 17 out of 22 countries recommend testing every 3 months. There were also just to mention, out of the 3 countries that didn't have specific information, 2 of these did actually mention serology, but we weren't able to distinguish what that really meant. So we put it in a category of not enough information. So testing by pathogen, continuing to look at this more specifically, we know that WHO recommends not testing for gonorrhea and chlamydia for people at high risk of infection, and sampling all at anatomic sites and pooling those samples. This is a general guideline. We know that the reality of implementation of this is really challenging, given the cost and also the lack of tests out there. But only one country recommended PCR testing for gonorrhea and chlamydia, and no countries mentioned the need for sampling all anatomic sites. So even though there's not great tests out there, it is something countries should start thinking about and considering when, in terms of integrating STI care. There was also no mention of collection of samples for gonococcal AMR. We know this is a rising issue, and it's really a missed opportunity not to include PrEP sites to collect samples for gonococcal AMR. So finally, I'm just going to mention partner services. Partner services are an integral part of quality STI service. We all know this. They prevent reinfections. It's ethical among partners. It breaks the chain of transmission. But no countries mentioned partner services or how to conduct contact tracing, and no expedited partner therapy was mentioned in any of the guidance documents. So again, it's really a missed opportunity. Even though partner services can be tricky and it's quite complicated, it's something that is really essential to break the chain of transmission. So coming soon, WHO recommendations on a range of effective STI partner services approaches will be available. So we're looking forward to that and being able to adapt those into guidance. So in conclusion, we did this review just to, provide some baseline to monitor progress. Some guidance do not mention STIs or refer to STI guidance or algorithms. That's a missed opportunity. Syphilis testing should be recommended for people who use PrEP. Using dual HIV syphilis testing is a great opportunity. Gonorrhea and chlamydial molecular testing, due to the high cost, is unrealistic in most LMICs. We know this. However, we need to continue to push for R&D and low-cost, easy-to-use quality diagnostics. And although most recommend every 3-month testing, more research is really needed to determine optimal frequency. Recent reviews suggested every 6-month testing is more feasible, less costly, and with similar outcomes. And finally, partner services, it's a missed opportunities not to include these. EPT could be considered for gonorrhea and chlamydia depending on the context and population. And then, as I mentioned, AMR, it's an opportunity. PrEP and STI services could be an opportunity for monitoring trends. So I know today I talked mostly about PrEP, but I do want to just add something that STIs, we're talking about integration overall. It's not just PrEP that STIs can and should be integrated in, but this was just one of a real clear area. So thank you very much. I'd like to acknowledge my colleagues who gave me amazing support. And I look forward to hearing the rest of the webinar. Back to you, Georges.
Thank you, Erika, for your very interesting presentation about the national recommendation. And if you have question, you can go to the Q&A module at the bottom of the slides. And we are going to move now to Dr. Maeve de Mello. Dr. Maeve de Mello works at WHO Global HIV Hepatitis and STI Department as a technical officer for STI prevention. Before moving to Geneva in 2020, she was the PAO WHO Regional Advisor for HIV STI prevention and testing, and the focal point for the initiative on the elimination of mother-to-child transmission of HIV and syphilis. Dr. de Mello, we're going to entertain us about the WHO guidance for the integration of STI services when offering HIV PrEP. Over to you, Dr. de Mello.
So, as my colleague Erika Spillman has mentioned, there is recent guidance from WHO for the integration of STI services into PrEP, services that can also be used for key population services. So this new document is part of a PrEP implementation toolkit as one of the new modules, and it can be accessed at the WHO website or the QR code that we're going to share. So, of course, we don't want you to read all this, but what I want to stress is that the module we prepared into two separate parts, one focusing on program managers and one focusing on service delivery managers and healthcare workers, and trying to be as practical as we could. The module is framed within WHO differentiated service delivery framework, having people at center and thinking about where to offer services or where to integrate, what to integrate, how to integrate, and who should be supporting the integration based on the context, based on the client. The module also takes a stepwise approach to the integration because we do understand different contexts and different resources in different parts of the globe. So, but we do want to every single service to move from nothing to something. And the something can be as simple as asking clients for signs and symptoms and being able to offer, syndromic management. So the next step, and we saw based on Erika's presentation, and many countries in Africa already using this, is the addition of syphilis testing, a rapid test to the syndromic management. And as in contexts where it's possible to add molecular testing, particularly for gonorrhea and chlamydia, and vaccination for hepatitis B or HPV, that's of course are going to move towards a much more integrated and complete service focus on the client. Just as a quick example that WHO has a costing tool and forecasting where services can start adding packages and see how much would it cost for them within a 5-year period. So if I just add syphilis rapid testing, or if I do with the molecular testing, what does that mean to my budget? Next slide. So the module also have a very quick at a glance summary of all the possible ways and services that you can add when offering STIs within the PrEP context, that goes from the information to referrals and when it's not possible to treat the person at the site. And also the STI services, they can be integrated considering where and how services are delivered. So of course you cannot offer everything everywhere, but it's possible to offer quite a bit in many different settings, from virtual platforms to home delivery of services, pharmacy, sites without laboratory facilities, etc. So in terms of who is, could be helping to integrate. So the module talks about capacity building and training, the critical element of engagement of peers and communities, and looking at the different service delivery models and with focus on self-care to, with the aim of empowering people, but also decreasing the workload within the system. So emphasize that task sharing, task shifting are really critical to provide integration to more people. So I'm just going to bring a few highlights from the module. So the number one, really thinking one size does not fit all. So what can be integrated and where? Counseling is essential, is an essential component for client-centered care. But counseling aimed at changing people's behavior has just been shown to be ineffective to reduce HIV and STI incidents. But counseling, to provide information, exchange of support, of information to clients, for them to make an informed decision, having a plan to how best address, take care of their health within their context is something super important. And of course, always voluntary. So the three aspects we want to emphasize is the self-care, which is really core to people-centered approach. We are going to have an upcoming recommendation on syphilis self-testing, but WHO has already a recommendation for self-care and self-sampling for chlamydia and gonorrhea, and reminding that pooling samples allows for the collection of testing for the different anatomic sites where people can get an infection for the same amount of money. So there's guidance on that in new WHO guidelines for key populations. So the fourth message is that rapid diagnostic tests are critical to improve service delivery and effectiveness and its efficiency. And when you're thinking about the dual HIV syphilis test, it can have a really minimal budgetary impact, at least to start screening for syphilis. There's an upcoming also recommendation from WHO for use of rapid dual treponemal, non-treponemal test, which means it can help countries or providers to know if we're talking about an active syphilis infection, because the regular just RDT, for syphilis can't really differentiate the two. And one thing that I want to emphasize is that it is pretty safe to use penicillin benzathine at the level of the facility. So just put an article, which is quite old here, but we know that's a huge resistance of providers to be providing BPG with fear of very serious adverse side effects. So the other message that the module brings is the possibility of using different strategies of partner services that are currently used for HIV that can easily be used for an STI. So a service that's incorporated syphilis rapid test, the dual HIV syphilis rapid test. If you have a positive test for syphilis, you definitely should be going after partners and supporting the client to go after partners and help them to be treated. So, and as Erica's mentioned, so it's very important that both KP services and PrEP services, that they can really function as like the early warning for outbreaks, as we just saw with Mpox, and also for AMR in case the country, it's where you're going to get lots of samples and really support antimicrobial resistance monitoring. So with that, I acknowledge my colleagues as well. I want to mention that more than 60 reviewers have looked at this guidance document to make it most appropriate and practical as possible. And the key points, as you saw, were driven by the current national guidance at country level that Erica has just presented. So that presents as a baseline to implement this document. Thank you very much.
So let's introduce Dr. Chidoziva Shikwari. He is an epidemiologist with experience leading HIV and STI implementation research studies among adolescents and young people. She is based in Zimbabwe and holds a joint appointment with the London School of Hygiene and Tropical Medicine and the Health Research Unit at the Biomedical Research and Training Institute in Zimbabwe. Dr. Shikwari will talk about the community-based integrated HIV and sexual and reproductive health services for youth in Zimbabwe, the SHIDZA and STIX trials. Over to you, Dr. Shikwari.
Thank you very much for the introduction, Georges. So as he mentioned, I'll be presenting on 2 cluster randomized trials that were conducted in Zimbabwe and ended earlier on this year, the STITCH and the CHIEDZA trial. So for some background, the CHIEDZA trial was aimed to investigate the provision of community-based HIV services, including testing, ART initiation, and adherence support, integrated with comprehensive sexual and reproductive health services for youth in Zimbabwe. The target age group was young people aged 16 to 24 years, and the intervention was conducted over 30 months. Nested within CHIEDZA was the STITCH trial, and STITCH is an acronym for STI testing in CHIEDZA. And STITCH investigated the impact of comprehensive STI management, including etiological testing, on the population prevalence of STIs among young people. And this study was conducted in 3 provinces in Zimbabwe. And so we offered a comprehensive package of services. And as you can see from the menu card that young people were provided, there was a whole host of things that they could access in addition to HIV testing. These things included family planning products and advice. We also offered condoms, general health information and counseling, as well as menstrual health management products, including reusable pads and menstrual cups, as well as pain management. There was a list of services for both males and females in these communities. And as part of the STI testing trial, we also had some dedicated IEC, so information and educational material on the STI testing services that were available within CHIEDZA. We referred as well to other services, and part of the referral services were actually PrEP. At the time when the trials were started, PrEP was not widely available in the public sector in Zimbabwe, and so we actually referred to other facilities for young people who wanted PrEP, as well as voluntary medical male circumcision. In terms of how we offered STI testing within this trial, so the standard of care for STI services in Zimbabwe is syndromic management, but we did offer etiological testing for chlamydia, gonorrhea, and trichomoniasis as part of the study. For chlamydia and gonorrhea, the test was done in a laboratory setting using a gene expert device. And what that meant is young people could access their results within 1 week of leaving their sample at a CHIEDZA site. We used urine samples for the gene expert testing. Any young person who tested positive for any of the 3 STIs, we would follow up via telephone for a period of up to 3 months. TB testing was done using a point-of-care lateral flow test, and results and treatment were available on the same day. We offered young people who tested positive for any of the STI partner notification slips, and their partners could come back to Chiedza to access free treatment. All of the services, including STI testing, were provided free of charge. And so I'm just going to share with you some of our findings in terms of uptake of all the integrated services. Overall, we had over 78,000 visits to Chiedza from over 36,000 unique clients. Majority of the visits were from females. So where we had over 27,000 visits from females, we only had about 9,000 males who came to the service. And this is a slide that just shows you service uptake with males on the left and females on the right. And as you can see, one of the key things that males came to the service for was HIV testing. So over 80% of males came to access HIV testing, but over 90% of males in both age categories also accessed condoms as part of the Chiedza trial. We also had an SMS intervention, and what this entailed was young people could sign up to receive SMSs on contraception, and a lot of males really took up this intervention and really liked receiving these SMSs. When we look at the females, almost every young woman that came to the Chiedza service took up menstrual hygiene management products. So we have over 95% uptake of menstrual hygiene management. Similar to males, we had over 80% uptake of HIV testing, but young women also, in addition, took up pain management for their menstrual health and also the SMS intervention. So overall, we conducted over 38,000 HIV tests, and over 84% of young people who were eligible took up HIV testing at Chiedza. When we look closely at the uptake of STI testing and treatment, similar to HIV, we had very high uptake of STI testing with over 86% of young people getting a test. The prevalence of chlamydia and gonorrhea was 16.3% among those who tested. And as you can see, in females, it was almost 1 in 5 young women who tested positive for either chlamydia or gonorrhea. Treatment uptake was 60%. And we also observed high incidence of chlamydia and gonorrhea among young people who retested. The prevalence of TB was 7%, but in contrast, what you'll notice is that almost every young woman who tested for TB also received treatment on the day. And this is compared to the 60% treatment uptake for chlamydia and gonorrhea, where they had to return, and we also followed up. The uptake of partner treatment was only 5.7%, and this is among people who came back to our service to access treatment. So I'll just share some of the key lessons in terms of integration that we picked up from our process evaluation of the 2 trials. So why did Chiedza work? We believe one of the main reasons why it worked is that these were free services and commodities offered to young people directly to them in their communities. We offer the service in youth-only spaces where being young was celebrated and young people also felt safe. We had also a youth-focused interface, and so we had youth champions in our communities, and these young people went out and sensitized and mobilized other young people in the community. We also had youth workers who were part of the service providers in the Chiedza sites. And key to this webinar, and one of our findings from the process evaluation, is that the one-stop shop approach was found highly favorable by young people. When we conducted our prevalence survey, we found that 24% of those who reported to have attended Chiedza said they took up services they actually had not planned to take. And at each visit, the mean number of services taken up was 2.4 for each client. And while there was initially a fear of HIV and STI testing before young people attended, once they arrived, we found that the providers could support them in overcoming these fears, and they did manage to take up more services than they had initially planned. And so there was a value that we observed in integrating the different services. Another one of our key findings was that there are gendered hooks that pulled young people to come to our services. So particularly for young women, the provision of menstrual health management product meant that even though they came in to access pads, these young women also ended up taking other services. And here's a quote from a young woman who says, "I came wanting pads and then also got tested for HIV." For young men, we found that condoms served as a hook, and also STI testing, treatment, and management served as a hook for young men within Chiedza. And so one of our key findings and lessons that I'd like to share is the importance of getting young people through the door and how we can do this. There's a need to generate youth demand, and how we did this within Chiedza was community health workers and peer supporters. We did a lot of work mobilizing and sensitizing hard to reach young people in the communities. There's also a need to demonstrate youth readiness. And so our providers were non-judgmental and provided support. And we offered this through providing training, repeat training to the providers as part of our intervention development. And key also to getting young people to the door is the provision of free or subsidized products, particularly menstrual health management products and also other sexual and reproductive health products. And so when it comes to operationalizing our learning, it's important that we listen to what young people will attend for, and what learning can we integrate into existing health services. So the first is that there's a need to tailor services to young people's priorities. So what we found were our hooks, the menstrual health, the STI testing, and those can be useful in bringing young people through the door. STI testing, again, acted as a hook, but there's a need to consider what else needs to be inputted to make this effective. So number one, we observed high prevalence, and what are we going to do about this? And there's a need for the STI testing to be done more effectively and consider the costs that are associated with delivering these interventions. And finally, with STIs, there's a high risk of reinfection, and we found low uptake of partner notification. So there's a need to consider what other avenues can we address the issue of reinfection and partner notification in young people. We observed that there's groups that we still didn't reach, and there's a need to consider what else we still need to do to reach them. So for example, we had lower uptake of services among males, and we also found in our qualitative work that there's a need to also consider interventions that are non-health focused and use them as potential hooks to improve health outcomes. And finally, I'll just talk about where we can integrate services, or where we can deliver integrated services. Firstly, as part of primary care services and in HIV clinics, as has been highlighted by the previous presenters. We also showed that it can work as part of community-based services, and this is exactly what we delivered in Chiedza. And finally, considerations should also be made, particularly for young people, for delivering these services in educational settings as well. I'd like to acknowledge our team, our partners, and our funders, as well as the young people, their families and communities that were part of this trial. Thank you.
Thank you. Thank you so much, Dr. Chitwari. And I think the results of the trials were very, very compelling and definitely will guide for appropriate actions. The lesson learned should also guide us, including the one-stop shop as an integrated service model. And we see the added values of integrated services, for youth and adolescents. So, Professor Seika Molik is the Director of Implementation Science at WITS Reproductive Health and HIV Institute in Joburg, South Africa, and the PI for Project PrEP. She is a medical doctor with a PhD in infectious disease epidemiology from the London School of Hygiene and Tropical Medicine. Dr. Molik will talk about the integration of STI management into PrEP programs, a South African experience. Over to you, Professor Molik.
Thank you. Jacques, could you please share my slides, please? Thank you so much. Thank you. Good morning, everyone. I'd like to thank WHO for this opportunity to present a case study from South Africa on integration of STI management into PrEP programs. Next. And I just wanted to say that all photographs that are used in this presentation are courtesy of our UNITAID funded project PrEP. Next. Next slide, please. Thank you. So a recent UNAIDS report highlighted that although the numbers of new infections in East and Southern Africa is declining, adolescent girls and young women in South Africa remain disproportionately affected by HIV, with an estimated 52,000 new infections in 2021, accounting for almost a third of South Africa's new HIV infections. HIV incidence in South Africa amongst adolescent girls and young women is almost 4 times higher than the male counterparts. And South Africa also has some of the highest rates of STIs in the world, with rates of curable STIs highest in younger people, particularly amongst young women. And studies have also reported very high rates of both incident and prevalent infections amongst PrEP users. And a meta-analysis actually showed that almost a quarter of young women have a treatable STI. Our prevalence of congenital syphilis has also been showing an upward trend in these recent years. So amongst young people, we see a high burden of disease that coexists with significant health systems and social barriers, both to access to information, but also to services. Next slide, please. So South Africa was one of the first countries to roll out oral pre-exposure prophylaxis for HIV infection to populations who may benefit. And initially was rolled out targeting key populations, and then later on to adolescent girls and young women as part of a combination HIV prevention package. Currently, South Africa has initiated over 1 million individuals on PrEP through over 3,000 of the health facilities, and that's through the majority of health facilities in the country. Screening for STIs is part of the integrated PrEP service package outlined in our national PrEP guidelines, and facilities are predominantly providing the syndromic symptom screening. National STI guidelines also recommend integrated services with the provision or linkage to PrEP services for HIV negative clients who might benefit. The STI guidelines also make provision for a diagnostic approach to STIs for adolescent girls and young women and PrEP users, but implementation is limited. Next slide. So this slide shows the currently widely implemented service delivery model, which consists of information and linkage to services through national digital platforms and health talks in facilities and in the community. Client information and available IEC materials on STIs initially were very limited, and existing materials focused mainly on HIV and PrEP. The use of diagnostic screening was limited, and even in some sites with GeneXpert machines, the waiting times were considerable. The reliance on syndromic management is likely to miss many asymptomatic and infections and potentially overtreat vaginal discharge symptoms. Partner notification and treatment are also challenging. Once linked to care, STIs are syndromically managed. Partner notification and treatment are recommended. However, it's poorly implemented. In our guidelines, there's also provision for expedited partner treatment, but it's not implemented. We have a national quality of care tool. It's called the DISCA tool. It exists, but it's underutilized. And there are some limitations, including limited access to information for young people and challenges with linking people to services which may not be youth-friendly. Although routine syndrome screening is outlined in the guidelines, it's not consistently implemented, and some facilities still have a very siloed approach, and we also have no routine indicators to measure integration. Importantly, service delivery models have been the same for a long time and have not been guided by empiric data on youth service delivery preferences. Next slide. So I want to tell you a little bit about Project PrEP. It's a Unitaid funded project, and it's implemented in 8 fixed and 4 mobile facilities in 4 high priority clusters in 3 provinces of South Africa. And the delivery model includes strong demand creation interventions through both online and community platforms. And the fixed facilities provide an anchor for services with a roving mobile unit, which extends the reach of services in the surrounding catchment of 2 fixed facilities. The interventions are delivered by nurses, counsellors, and peer educators in line with the national guidelines. And the project also implements and evaluates service delivery adaptations and innovations through a number of sub-studies. Next slide. So when we started the project, we used the national DISCA tool at these sites to identify areas to strengthen. And we found that there was a need for provider training, especially in facilities with high staff turnover. Many of the clinics had old guidelines, and STI syndromes were often over or undertreated. The routinely collected data at health facilities was only male urethral syndrome, with no data on other syndromes or on partner notification. We also saw drug shortages and equipment shortages, such as specular and examination lights were identified. Next slide. So one of the objectives of the service delivery model for Project PrEP was to strengthen STI integration within these PrEP services. And the project sought to strengthen the existing model by adding activities and innovations that are highlighted in green. And these included intensified community campaigns, outreach through CBOs, and the development of a number of digital tools. And we developed these tools in collaboration with end users and with the National Department of Health. And that included a chatbot. We had various social media platforms, a website with a clinic finder function. STI information and linkage were integrated into these platforms. Screening for STIs was conducted at both health facilities and communities through mobile clinics with capacitation of health workers, and we had enhanced monitoring of STI screening and management. In a subset of clients, we took STI samples from PrEP users on site, and we sent them off-site to laboratories for testing, with clinician contact for results and return to the clinic if treatment was required. Next slide. So what we've learned from our sites, we've learned that routine symptom screening is feasible and can identify symptomatic STIs. And this slide draws on routine monitoring and evaluation data and shows that in that period of over 25,000 clients, of whom the majority were provided PrEP services, 92% were screened for STIs at their first visit to the clinic. The baseline prevalence of having an STI symptom was just under 9%, and this varied with age and gender, with the highest prevalence of symptoms amongst the 21 to 24-year-olds. So symptom screening works to identify some STIs. Next slide, please. At the project sites where we implemented the diagnostic testing and samples were taken, we confirmed that there was a high prevalence of any curable STI amongst both male and female PrEP users enrolled in the STI sub-study, with a high proportion being positive. In women, this was about 33% and 39% amongst men. So it's about 36, almost 36% in this group. Prevalence amongst females by age, which is the slide on the graph on the right, showed that the highest rates of curable STIs were in the age group 18 to 20, with an overall prevalence of a curable STI at 44% in this age group. Next slide, please. So the diagnostic approach, though, can identify a lot more infections, but it's not without challenges. This model required the availability of a laboratory with capacity to process the specimens. We had issues with it requires transport of specimens. Lab tests are very costly, and results are not available immediately. So clients are actually required to return to the clinic for treatment. Consultations became longer, and some clients were not always willing to wait for specimens to be taken. Availability of correct drugs remained a challenge at sites, and partner notification and return for treatment also remains a challenge. Mobile clinics also require space for specimen collection. Next slide. But what we know from our face-to-face and our online engagement with young people is that they want information on STIs. And this slide from some of our online platforms shows that they have a lot of questions and need to be linked to services. So they're asking, and I won't read all of these, but where can I get services for STI screening? Please tell me more about STI screening. I want to test for an STI. Where can I go? Next slide, please. And this is just some examples of some of the STI-related posts on our social media platforms. Next slide. But what do young people have to say about when and where and what they prefer with regard to service delivery for STIs? So with funding from the National Institutes for Health Research in the UK, and in collaboration with the Brighton and Sussex Medical School, we conducted a discrete choice experiment to see what preferences for service delivery were amongst youth. And we interviewed just under 500 participants, the majority of whom were female, and the mean age was 26 years. And we found that there was a preference for self-sampling, short waiting times with the receipt of results preferred either within 2 hours. STI result notification via SMS or online platforms was also preferred, as was access to treatment through pharmacies and consultation through telemedicine. For partner notification, expedited partner therapy was preferred over notification slips or providers reaching out to contacts. Next slide. And when we did some further analyses on these data, we saw that there were 2 distinct groups. One, which was about 2/3 of the group, had a preference for self-care and out-of-facility management. And these tended to be over 25 years and in rural locations. They wanted treatment issued at the same day at the clinic. They preferred self-sampling. They didn't want to wait for results. Also preferred expedited partner therapy and same-day results through an online platform. And we had a second group, which was a smaller group that preferred more health provider-driven care. And they didn't mind how the treatment was provided, but they preferred sampling by a healthcare provider and to wait at the clinic to receive results from a healthcare provider, and also preferred partner notification through a healthcare provider. Next slide. So I'm going to end with some recommendations and some conclusions. And these are areas that are, in fact, also highlighted in the new WHO implementation tool. And the first one is to strengthen monitoring of all aspects of STI management at the program and the individual level. And this can be used to identify gaps in service provision, training needs, drug stockouts. Secondly, extend appropriate STI screening to all settings and all populations that might benefit from STI services. We found that screening for STI symptoms was feasible, and it can actually help identify symptomatic cases. Conduct etiological screening in other populations, and we found that the etiological STI management was feasible, and it identified a lot more infections, but it's not without challenges. And we still urgently need rapid, cheap point-of-care diagnostics. We also had challenges with partner notification and treatment, and we need to continue to improve partner notification, treatment models, and also look at models like expedited partner treatment. Thirdly, we need to understand values and preferences for service delivery and expand choices to be able to provide these options. So reaching young people at places of convenience, really extending and evaluating adaptations to models of care, and also leveraging and expanding online platforms and digital tools. And I'd like to end, next slide, please, by acknowledging my colleagues, our funders, and the Department of Health. Thank you.
Thank you, Professor Muley, for your, extensive presentation. Very interesting. So now we're going to have a presentation with Elsie Alala. Unfortunately, she is not here physically with us, but she has pre-recorded her presentation. And Carl Naim Waka will be here to respond to the questions afterwards. So I'm going to present Elsie. Elsie is a nurse by profession with more than 30 years of experience working in health facilities and public health in the community. She is a technical advisor to the Kepistar project with IntraHealth Namibia. Elsie has worked with key populations who are sex workers, gay men, and men who have sex with men, transgender individuals as well. So as I said, Carl will step up at the end of the presentation in the Q&A to respond to questions related to SC presentations. So next to SC now for a presentation.
I'm going to speak on using an online platform to promote testing, manage and monitor services for HIV and other STIs. Health Namibia, it is a local non-governmental organization that is affiliated to IntraHealth International in North Carolina in the USA. We work with a consortium of partners, including key population-led civil service organizations to implement the projects. The Kepistar project's goal is to strengthen HIV prevention, treatment and care for key populations, mainly the sex workers, men having sex with men, and the transgendered individuals. Our implementing sites are on the map on my right, and these are in 10 towns and the main thing we can see here is that they follow the commerce routes, the main trade routes coming in from Zimbabwe, Botswana, Malawi, Zambia, Angola in the northern borders, and all the way to the coast in Walvis Bay, Swakopmund, with Windhoek being the central town, and down in Keetmanshoop going to South Africa, or Hobabis, which takes us to South Africa as well, but via Botswana. The services offered are HIV testing services, condom, lubricant promotion and distribution, screening for STI symptoms, which is done at baseline and at every visit. That is for PrEP or ART refills and TB, syphilis and hepatitis B and C testing at baseline, and also it's repeated yearly. We do referrals and linkages to care for people with positive screening or testing results and other health needs that they may require. The background of QuickRes is that in 2020, there was the lockdown due to the COVID pandemic, and this caused closure of some health facilities and the hotspots where the sex workers gather. And we then launched QuickRes in 2020 as part of KP Star project to ensure that access to services continued. Since we also found out then that the key populations were now utilizing online services more. So QuickRes is a multi-country web app for online appointment bookings and for case management. And due to its adaptability and to improve on its utility, any new features can be added as needed. In Namibia, QuickRes has the STI features enabled, and we are using them. For the clients, QuickRes is designed to empower clients to book their appointments for HIV or STI testing, PrEP or ART refills. We can send SMSs that are system generated for the reminders, for follow-ups, and for case management. QuickRes allows the provision of virtual support, counsel and ongoing counseling, and it prompts clients to screen for risk-taking behaviors and symptoms of HIV or STIs and for COVID-19. And based on clients' responses, QuickRes recommends them for HIV and STI testing. Returning clients and those opting to skip the risk assessment can still book for their STI services on QuickRes. In Namibia, this is how our face of QuickRes looks like at the end of the client's phone. And it's simply a social media promotion which brings clients to QuickRes, and the risk assessment tool helps clients to decide what services to actually choose, and clients can choose their preferred provider, dates and time for their appointments. As you can see in the last phone there, somebody is in a Rongo region and they are looking at either going to the Coastal Clinic in Walvis Bay or the DRC Clinic, which is still in the same region of Irongo. QuickRes for facility managers and decision makers is such a wonderful tool in that for every service or every inquiry that a client made on QuickRes, the managers are able to run reports on the same, and they are able to quickly, case managers are able to quickly respond to the clients. And for decision makers, they can actually use the real-time data as they see it coming through. And most of all, you can render support supervision to the staff, especially with those who are a bit shy and slow to use the technical part of using the telephones and going on the web. QuickRes, the results of QuickRes implementation. This is just a snapshot that in those same 68 facilities in the 10 regions, of the 44 case managers who were using QuickRes, we found out that there was low uptake of self-screening questions for STI symptoms, maybe due to the stigma for STI still remaining higher than that of answering the questions for HIV. there was low uptake of appointments booked for STI, even when the clients were prompted to do so. But 5,659 appointments were made for PrEP in the period of October 2021 to August 2022, and STI services were offered to all of them. 84% of appointments happened, and upon arrival, all clients were offered and accepted to be screened for STI symptoms. They were also tested for syphilis, tested for hepatitis B and C, and they were also screened for TB. The benefits of QuickRes are quite plenty. QuickRes enhances integration of service and promotes a people-centered approach to key populations. It helped with the migration from paper-based to electronic case management for HIV testing services, PrEP, ART, and STI services. It improved overall efficiency in case management and made data easily accessible in real time for decision-making. And it ensured data security and client confidentiality, which is much needed with our key populations. And with QuickRes, we managed to promote online outreach using our online outreach workers and with influencers whose blogs or whose sites are also linked with QuickRes. And QuickRes functions as an educational tool as we are able to keep pushing educational messages. And for appointments, it does decongest facilities and shortens the waiting time. QuickRes also has its challenges in that, which we have already noticed, the low uptake of self-assessment of STI symptoms and STI-related appointment bookings, and migration to the electronic case management system for the ministry facilities remains a daunting task in that the upfront cost to implement and roll out QuickRes, even if likely to be a cost-saving strategy, is a bit of a challenge. The future of QuickRes in Namibia is that we are going to be able to incorporate the client satisfaction survey into all the facilities, health facilities, and we can get feedback from the clients on issues of the facilities being KP friendly or how did the service go in overall. Otherwise, introducing and expanding QuickRes to other Ministry of Health facilities has started, and it will allow for follow-up and monitoring of STI test results and treatment. And the future also is that funding and sustainability is still an issue. Thank you very much. This is where I'll end with the presentation, and you're welcome if you've got any questions.
Thank you, Elsie, for this presentation of this online platform. The QuickRes was a lot of benefits, of course, some challenges, but a lot of benefits to taking into account. So we'll move now to the next presentations. It's about the video for the voices of the community from our South African colleagues. We can pass the video now.
I'm Normalizo Mwivana.
I'm Ntombiza Madolo Elafumba.
Young people are not confident enough to tell that they have an STI. While they were looking you in the eye, talking, but when it comes to STI, they sort of become shy. So it's very important that I make them feel comfortable and tell them that STI can happen to anyone, especially if one has not used the condom.
With the young people, I always experience that even if the child is complaining of something, you'll find out that she will say, I've got a backache, I've got something else totally different from STI. But that we can get the information. We need more time, more strategies to motivate them, but we are trying all our best. Even me, I've got a scenario where this lady is coming in for family planning, and then at the end, When I was probing the questions, she voiced out that she's got pimples on her genitalia. When I look at it, it was really worse. When I talk of that, she said she is aware, but that is how her partner is enjoying sex with her.
It is easy, only that you tell yourself that you have to provide a comprehensive service, a holistic approach. You dwell even beyond the STI. It's only that you need to have all the resources at your disposal.
When we integrating these services, we need more resources. And then you know that you're going to do the thorough examination and the thorough treatment with the client.
For me, integrating STI in the services, the management must understand that it takes more time, because first of all, we have to put the client at ease, make the client understand that we have to look at private part, and also regular in-service training so that we keep ourselves abreast of the new developments. The challenge that you are encountering is that clients don't bring their partners. The importance of having our linkage officers, people who are going to help us to call the partners, is also very, very important. I'm saying young people out there, there's a lot of information about STI. Get into your phone and check on Facebook. Don't be shy. Please come to the clinic. You'll be treated, and also you'll be given resources so that you can be able to take to your partner. Sexual health is very, very important. It determines your future.
I'd like the young people to understand that times that they are living in is totally different from the ancient times. Utilize the health facilities, make use of the health education that is done at schools, at health facilities, and the booklets or pamphlets that are distributed out there.
Wow, it was really cheerful to see that video, and I think our colleagues of South Africa, they did a great job, and kudos to them. And now we are going to monitor the Q&A session and to see if there were some questions left to answer live. I think Dr. Shido has a question that she can answer for Maria. Shido, over to you.
Thank you, Georges, and thank you, Maria, for the question. I think I agree with you that 60% treatment uptake is not optimal, as well as compared to the very high uptake that we had for the point of care test for TB. And I'd say there are multiple reasons that we think this may have happened. The first being that we were only in each site once a week. And so that meant that if a young person left their samples today, they had to come back for their treatment. And the earliest occasion would be a week after the day that they left their sample. We followed up via telephone over 3 months, but another one of our observations was that many young people did not have mobile phones. And so that meant that we couldn't contact them to ask them to come back for treatment. And then finally, one important thing to note is that majority of the STIs that we diagnosed were asymptomatic. And so if a young person is told that they do have an STI, but they don't actually present with any symptoms, the motivation for them to come back to the site is much lower. And I'll just come back to what I said initially, in the sense that if we do have point of care diagnostics, we observed that the treatment uptake was higher. And I think this is one critical gap that needs to be addressed. Thank you.
Thank you, Shido. Carl, are you here? Do you see the question in the chat, Carl? Can you answer?
Sure, try to be quick. So the question that we have there, the benefits and challenges associated with utilizing partner services to track and manage potential STI contacts. So partner services, it's quite complex, but can be extremely effective. And I think what we have to have in mind is that is always focusing on the person and providing them with different options to help them to notify their different partners. And also thinking, have in mind that interpersonal violence needs to be explored. And in case of a situation like that, it's not something that you want to be pursuing. So some clients, and I think Psych explored that, would prefer, for instance, the option of taking the treatment to their partner. Some clients may prefer to bring their partner and the provider helps them to notify. Some will prefer that the providers call them. So it's really a tailored approach is where we are seeing the best results. So we're going to have more guidance on this soon from WHO by the end of this year or early next year. It's really focused and be sensitive to the person and to their needs for their different clients and provide options. Thank you.
Thank you, Marive. So there's an attendee that has a question. So can you just ask quickly the question, please?
Hello, good afternoon.
Good afternoon.
Yes, I have listened to all the presentations that have been presented. So one issue that has come out clear right there is to do with PrEP uptake. Talking from Chiedza, talking from South Africa, I understand to say we are having oral PrEP and injectable PrEP. What has been the uptake of the same, and what are the issues? Do these countries also have resistance as we do have here in Malawi? So that maybe we can learn from the same for programming purposes. Can you just have come out clear from Chiedza and all the guys that have presented, I think from Namibia, South Africa, and the last one who did the presentation, can you just come on the same so that maybe we have a key takeaway on the same?
Maybe Saika could try to answer that.
Yes. So if I understand correctly, it's about uptake and HIV drug resistance. So it's an important question. In fact, South Africa is one of the countries that's done really well in terms of PrEP uptake, but and Africa as a region have done well. However, we're still behind targets. One of the, and I think just looking at oral PrEP and with the introduction of new PrEP options, which are also ARV based, it's important to have systems to be able to monitor HIV drug resistance. And certainly we've been doing that in South Africa within the context of our demonstration projects on oral PrEP, and there is a plan also to continue to monitor for HIV drug resistance. And so we do take dry blood spots from clients who are on PrEP that seroconvert, and it does get sent to the lab for HIV drug resistance testing. But I think the key message here is that it's important to try and monitor as we implement and expand PrEP options moving forward.
Thank you, Professor Mulik. So now I think we are at the end of the session. We exceed the hour. So we're going to thank again the most of the participants. We have over 300 participants at one time for this webinar. And the key messages we have for this webinar is we have 3 keywords. We have integration, we have people-centered approach, and we have the differentiated model of services. I think it's important, that programs, find this opportunity to improve STI testing and treatment and realize people-centered care. We have seen as well some strategies for partner services that can work not only for HIV, but also for other STI services. We have seen the results of the trials of Dr. Chido, who showed us that one-stop shop is a good model for integrated STI services and the added value, for the youth especially. And we are very eager to see the online platform that are some benefits, especially for the youth, and it's designed to promote clients testing and monitor STI services. The benefits were highly shown by Elsie in her presentation. And also the Professor Moulik presentation, the PrEP implementation model, it was very important to see the importance of monitoring STI services and the routine screening for symptoms of STI. And the recommendation for partner services and understanding of developing model of services for STI are important as well in the context of patient-centered care. So, as I said, the W guidance, as said by Maeve and Erika, they are there. They are there to adapt in our respective countries for STI management among people who use PrEP in the African continent. So we thank all the panelists for their time and their busy schedule to be here with us today. And we thank again all the participants for their questions, for their suggestions to join this webinar session today. And as we said in the beginning, we will share with you the recording sessions and the materials and the chats. And afterwards, there will be a survey that we will share with you at the end of the session. Please fill out the survey because it will help us to improve in our future presentations. So I don't know if any of the panelists has a last word before we closing the session. So if not, we wish that the session were very helpful to us and to you guys. And I hope the rest of your day goes well. Thank you and bye-bye. The session is closed.
Thank you very much, everyone.
Bye, everyone.